Thanks, John, and good morning, everyone. You might think that Ben and Jan and I spent weeks collaborating on the exact flow of this, and we had a couple of emails saying, I'm worried that I'm going to talk about what you're talking about, and Jan said, no, don't worry about it, I'm just going to do some case studies, and Ben said, I said, he's from planetary sciences, how could he? Anyway, I want to thank you guys for setting it up so well. We've talked about the what in public health, what are we modeling, and the how, and my job is to finish it up by saying for whom, and also in what context. What is it exactly that these models are supposed to inform? Why are we doing them and moving them forward? So I want to thank John and the Standing Committee for having this meeting. You guys have impeccable timing for a number of reasons. John mentioned the interim assessment report, which is going to put some meat on our mostly descriptive work with, oh, there's my name. I feel home. Which puts some meat and some quantitative estimates on our, or mostly a synthesis report. But also, it's going to feed into some really important work that CDC is doing right now with grantees at the state and local health department level, and hopefully guide them in the right direction. And as John mentioned, this was a huge year for climate change, and especially the health community being a much more visible topic in the past few years because of a number of efforts, especially the IPCC stating unequivocally or reinforcing the state of the science, but also the United States finally coming through with a new and original climate impacts report that has thankfully received a good bit of attention, especially within the federal agencies. And what they found and what the others have reiterated is that we have not only changes in the average mean temperature, but also the variance, which is extremely important when we consider these effects over time, that the distribution of these events on the tails of the distribution are going to increase. How do we model that using different time series approaches? And also that climate change will vary significantly by region, and in order to get a true sense of what the impacts are, we have to look at the regional scale. So Jan showed something similar to this, and I'm going to add a dimension to this. This is summertime temperatures, and as we animated forward on a decadal basis, you see two things. This is what Jan showed with his slide, except the observed evidence also shows a flattening out of this curve, which I think is much more important than we give it credit for, meaning that the tails of the distribution are going to be fatter. If we press down the middle of the curve or even make it flat, we can expect observations on the extremes much more frequently than we had in the past, which from a public health perspective, when it comes to weather, that's what we really care about, is the extremes, especially in an immediate acute response relationship. But also, we are observing that these impacts are unraveling much differently in different parts of the world. And I'm actually grateful for this slide because I can say unequivocally, because I'm from the South, that there is no global warming in Georgia and Alabama. Don't have to worry about it. You guys are fine. And then we move on to the next subject and not talk about climate change anymore. But this is important because we fund grantees from Florida to Oregon to Minnesota, and they're all grappling with this history of this climate record, and some places are experiencing this warming much faster than others, and they have to accommodate that into their approaches as things speed up faster. So John mentioned that our group, which many of the authors of the National Climate Assessment are in this room with us, not just in the health chapter, but in others, we had a number of key findings, and John mentioned this, that climate change threatens health in many ways. John showed the kaleidoscope image, which incidentally has a dual purpose. It's hypnotic. So he had it up sufficiently long that there's either two responses. Either you're going to believe it fully, or you're going to run out of the room screaming because it's bothering you. And nobody left, so that's good. But that showed you the range of effects that climate change will have. Broad. None of those that you saw on that screen were actually new threats. Those are just redistribution of threats. But certainly climate change will act as an effect amplifier of existing health threats. That certain communities are going to be more vulnerable. Where they live and what their particular vulnerabilities are key to those models. And as we all know, that public health actions, especially preparedness and prevention, can prevent some of this. So there is rationale for understanding where these trends are going. Now, we looked at the range of threats that climate change will exacerbate within the United States, and we were asked to then take a step back and say, well, how? You've described the what. It's air quality, it's vector-borne disease, it's waterborne disease. Okay, we get that. But how? What are the pathways in which people will be affected? And we came up with 3 key health threats. This is the manner in which these impacts will manifest. The first one is what I call death by 1,000 cuts, or more appropriately, morbidity and mortality by 1,000 cuts. And this is the effect that these multiple stressors, coming from multiple different sources, add to the cumulative stress that these communities already experience. That those that are already living in degraded environmental conditions near roadways and flood-prone zones are going to experience more of that in the future. And the cumulative impact, while it might be minor in a single event, but the cumulative impact could be very great. The challenge is to model the interactions between those stressors in these highly vulnerable populations. So what does heat waves do to these populations in addition to air quality at the exact same time? Because we often see stagnant air masses with heat waves. And that's been a challenge to model air quality and health. But what about aeroallergens as well? You throw that in the mix, or some other type of exacerbators. So we're operating in a condition where these communities are experiencing multiple threats at the same time. And how do we go about accommodating those in the models? And we see this in, this is one of our images looking at ozone, pediatric ED visits, just into 2020. Just down the road, next 5 years, we're going to have an increase. And you see that even in the New York area, there's a great amount of heterogeneity with the projections. So this isn't a prediction, the projections of climate impacts in these regions. And what that brings to mind is that certainly there's something to do with either wind speed or urban form that comes into mind. And as we look at these stressors, and our previous presenters already noted that the urban form provides an additional effect amplifier for many of these climate threats. This is some research that we funded out of Georgia Tech. Brian Stone is the PI, looking at global warming, background warming as measured in the global context, and actually he just looked at the United States, but looking at the rural areas of the United States compared to urban areas of the United States. And what he showed was that the trends are similar, except there's this added urban heat island effect that is adding to the global background level. So this doesn't work very well, but you can see the baseline 0, and the urban signal right here is the addition of the background warming plus this urban trend. The urban warming is actually much greater than the background global warming, meaning we have pockets of exposure that are going to far exceed what we estimate if we use a regional or a continental scale model, that we have to accommodate those fine scale enhancements of temperature as well. But it's not just limited to temperature. This is a famous study that our colleague Lou Ziska did looking at the impacts of CO2 on ragweed, showing a great difference between rural Baltimore over here in its production of aeroallergens based upon CO2 fertilization and temperature compared to the urban plot of ragweed that showed much greater enhancement of aeroallergens. How do we accommodate those in our models as well? So the second key health threat that we discussed was this complex emergencies, or disasters within a disaster. And the idea is that by the sheer magnitude of these events, meaning they're unlike anything we've ever seen before, Europe in 2003, European heat wave of 2003, Superstorm Sandy, they exceed the coping capacity of the critical systems that are in place to protect health, increasing the possibility or the probability that we'll have multiple system failure. So not only is health compromised, but the ability to respond to these disasters through loss of telecommunications, egress and transportation, and electricity is going to multiply this effect as well. So by the sheer magnitude of these events are going to lead to potentially greater complex system failures. How do we model these things? We've talked to Ben, mentioned a bit about how we start doing that. But there are critical thresholds that are operating in each of these systems. And as we approach those, linearity is gone. How do we put that into the system and understand what those complex cascading effects would be? This is simple. New York City in 2003 with a heat wave and power loss increased dramatically all-cause mortality. So it doesn't just affect the people sitting in hot apartments. It's all-cause, both non-accidental and accidental deaths increased dramatically in this period. So this is just highlighting the importance of electricity in these systems. But those effects expand much more from the acute, the short-term, or the localized. This is the impact that Hurricane Katrina had onto those 800,000 people that had to leave New Orleans. So we have an acute event, and we have this diaspora that just left New Orleans, and now they're all over the country. And what are those health effects as a result of loss of livelihood, loss of community, loss of family, et cetera, that are now manifest not in that one location, but all over the country? We did some early work we did at the Climate and Health Program at CDC was hazard vulnerability assessments for certain jurisdictions' health departments. And we went to Austin, Texas. We were working with them on developing indicators. And we said the first thing we need to do is understand what your hazard vulnerabilities are. So we looked over the meteorologic record in Austin, Texas over the last 20 years, and we said, okay, now you guys own this data. What is your single greatest hazard that you experience in Austin, Texas? And they said, hurricanes. They did. And I said, what? When was the last time you had a hurricane? They said, we've never had a hurricane. And they haven't. But every time a hurricane hits the Gulf Coast of Mexico, they get 30,000 people showing up at their health departments looking for all kinds of services that they can't afford. They haven't budgeted for it. And they're on their doorsteps, and they're taking care of them. This is 800,000 people. We have Katrina folks in my community in Atlanta. Actually, I drive by a billboard that says, trying to get home, we'll help. We took on a lot of folks. So this is another thing we have to model. How do these, not just the short-term effects of these complex emergencies, but the lingering long-term effects and how those permeate through the system? Okay, the third health threat is surprises are in store, and these are novel threats. And the idea is that large-scale perturbations to ecological systems bring about surprises. You couple that with the increase in global trade and travel, and we have the opportunity to facilitate local disease emergence. These might not be new diseases, but they're new for a particular area. The great example that we include is Lyme disease, and this is one of, it's not an early one, this is what, 2003, I guess maybe it is early, but Lyme disease modeling, looking at the interaction between climate trends, ecological trends, and social trends, and how those facilitate the emergence of suitable habitat for the tick that transmits Lyme. Now, we know there's a lot more to it than that. Recent work that Ben Beard and Mary Hayden and others have done, and Nick Ogden, show that it operates even at a smaller scale, that the behavior of the tick is impacted as temperatures rise. People's behavior certainly is as well. They might be outside hiking or gardening more. But what this study showed was that as we, and you can't really see it in this light, Jan was right there, but that we're going to see expanded and shifting range of suitable habitat for Lyme disease. So then I asked my colleagues at see, there it is, newest export to Canada. You're welcome. And as we look into the future, that, boy, we're going to be dealing with a lot more areas. What this tells us is that we better have laboratory capacity in Maine and New Hampshire to identify these novel pathogens as they emerge. We better be ahead of the curve if we suspect that they're coming our way. So I asked our colleagues at the vector-borne diseases at CDC, and this is some data that they shared with us. This is the case distribution, showing not density of cases, but where they're at across the United States. And the circles are just for points of reference, 1996 and 2011. And certainly from the time those models were projected, we're starting to see some of those anticipated movements in Lyme disease. Not just, I think, as a function of better identification or case finding, but just a distribution of the tick as well. And so this prompts us to say, what do we do? How can we get ahead of it? One of my favorite examples in disease emergence is a study that I got to work on in the Gulf of Mexico on ciguatera fish poisoning. Who's ever heard of ciguatera? All right, that's pretty good. So it's the most common type of seafood intoxication worldwide. We get a lot of it in the Caribbean and in Polynesia, and it's a big deal. If you have a reef system that is contaminated with Gambardiscus, you can't eat the fish really without accruing some level of risk in eating it. It's been in the United States confined to maybe a few cases every once in a while in the Florida Keys, but mostly Puerto Rico and that area. Well, we suspected that because sea surface temperatures are rising, that's one input in the system. Also, the appearance of about 4,000 oil rig platforms and artificial habitats in the Gulf of Mexico, that we have created perfect conditions for this. See, this is the reef ecosystems that are created by the oil platforms in the upper right. Lots of hard substrate that replaces this muddy-bottomed Gulf of Mexico, and with very vibrant fish communities. And we said, gosh, it seems like there should be Gambardiscus here, the organism that produces the toxin that causes ciguatera. And so we went about looking for it. And it's difficult when you're looking for an emerging infectious disease or toxin Because if you go right to the healthcare providers, they're going to say it's seafood intoxication of unknown origin. Got a bad fish, sorry. But no confirmation. So we went to fishermen who were probably the best observers of the type of fish they caught, where they caught it, because they have GPS, and we handed out beer koozies, the ones that you keep your beer cold, and we put a 1-800 number on it, say got ciguatera, and also these things. The beer koozies were much more popular. But all of a sudden we started getting cases coming in. Oh yeah, I got those symptoms after catching fish. I know exactly where I got it too, because I have my fish finder. And several of them had fish in their freezer still. So we sent it to FDA, and we identified 2 cases of ciguatera fish poisoning off Galveston, Texas, that confirmed that we have this northward distribution. So it's the combination of taking the environmental monitoring, the climate, the appearance of these coral reefs, or the development of them, and some shoe leather epidemiology to figure out, yeah, we have this. Now, how can we systematize this? How can we do this without just somebody and an idea for a beer koozie to put this into practice and start modeling it forward? Much more effective. I'll skip that because you guys already are zoned in. Another key thing before I go into what we're doing about it is the appreciation of scale in all of these activities, as there's extreme heterogeneity between urban and rural environments with regards to exposure to heat and air quality. Even within urban environments, as Ben said, there's a tremendous amount of variability from the census block group level, even the side of the street, that can affect these exposures. So we have to understand the appropriateness of what we're modeling from the global scale to the neighborhood scale, and whether we're modeling things temporally very acute and short term, things like a hurricane. But what if we start expanding that out and saying what are the distributed effects and the long-term effects, but also from administrative levels, and including things like policy levers. If we are to identify certain threats that can be mitigated down the road using things like urban planning, urban design, transportation, hardening of infrastructure, that we should be attuned to modeling those impacts in a scale that is conducive to the action that it might benefit from it. So, what are we doing at CDC with regards to health? Well, we have a program at CDC. It's appropriated by Congress, and it's the Climate and Health Program. We're about 17 folks now, and we have as our mission to help cities and states in the United States, we're a domestically focused program, to prepare for the health effects of climate change. Our job is to bring the climate science to public health. It's a very new idea for public health to consider. And also the ways in which they can incorporate that into their assessments and their hazard vulnerability assessments, and also into their thinking in the short term and the long term. We have as our centerpiece of our work the Climate Ready States and Cities Initiative, which is a funding mechanism to state health departments. We fund 18 of them, and we bring with that funding a model for adaptation planning that we've developed in-house called BRACE. And BRACE is here. BRACE stands for Building Resilience Against Climate Effects, and it's an approach that uses the principles of adaptive management, so loop learning, integrating what we've learned into the system, that starts with an assessment of climate impacts in a region. We forecast the climate impacts for a region and couple them with the existing vulnerabilities of that location. So we'll take Florida, for example, and because these are the states that we fund, everywhere from Florida, I mentioned that before. Those colors don't signify anything if you're trying to. They're 2 different groups of grantees, but they're no political affiliation in there. We get that asked a lot. But they assess what the historical meteorology has been and where it's going. Are the number of heat wave days going to increase dramatically or not so much? What about heavy precipitation, drought, etc.? And once they assess the climate part of that model, then they assess the vulnerabilities. How many folks do we have over 85? What is the other demographic, socio-demographic risk factors that might be relevant for their assessment? What they do then is they integrate that into a disease burden model, saying what are our existing exposure response relationship for this area, what are our existing epidemiologic profile, and how might that change into the future? This is a very, very difficult phase right now because they're dealing with a wide range of health effects, from direct effects of heat waves and air quality to indirect effects of ecological change and impacts on waterborne disease and vector-borne disease. And they're using multiple methodologies that this workshop will directly inform. I think this will set, as we go forward, some options for credible approaches to do that, because what they're looking at now is using linear regression models or expert judgment, which is my favorite, in estimating what they have to deal with. But the idea of that is to say, we have this existing epidemiologic profile. What might it look like in 20 years? So Oregon is preparing for heat waves, and they really don't have heat waves. So they're having a tough sell, saying, one of our main focus is heat waves right now. Well, getting ahead of the curve is important in a lot of these actions, and saying, we need to prepare our infrastructure for heat waves, because if we don't have them now, Seattle the same, we will have them, and it's going to be bad, because we just have to look at Paris 2003. But they want to match those, that future disease burden projection, with interventions that operate, again, at a scale from seasonal, getting a heat response plan and communication messages in, to multi-season, developing better predictions, siting cooling shelters, putting in urban greening, and all the way to the decadal scale, where infrastructure is hardened to deal with these future threats. And then that gets put into an adaptation plan that gets evaluated and reiterate. And this is a multi-phase process that occurs over multiple years. So that is really the output. The output of this meeting is going to directly inform their efforts, which are underway right now. And they're in year 2. So I want to thank you in advance for all of your hard thinking for our grantees on their behalf. And that's all I got.
Great. Thank you very much. I think these 3 talks have really set us off on a great path. It really has set up the questions that we need to ask for the rest of the time. We do have a few minutes for questions. Actually, we have a fair amount of time for questions. So invite anybody in the audience who's sitting, waking up now from the kaleidoscope, right? And to ask questions of George, or if there are questions that can be answered by anybody else to sum up the session, we'll be happy to entertain those too. And again, please identify yourself as you ask the question.
I'm Türkan Gardner, a statistician. Question and admiration for our last speaker, Dr. Luber, in terms of resilience. Everybody is interested in resilient communities. Resilient communities also means adaptation, and adaptation means education. As a statistician, I'm very curious to see how much level of statistics and understanding of quantitative principles are needed for communities, and what media, visuals or case studies, to get the individuals and communities aware and participating in efforts for resilience.
People are scared of statistics.
I know. That's why I'm asking.
And we find that there's a tremendous amount of trepidation when we go work with grantees on the use of statistical models. They have to be sold on it, be trained on it, and it's kind of scary. One of the challenges that we've had is that we work with 18 health departments, and they range from New York City, which is very sophisticated, as good a health department as you could expect, to others that are have fewer capabilities and capacities, much smaller. They don't have the resources, access to statisticians, et cetera. So we're having to kind of figure that out as we go along. It's one of our key challenges. But even more fundamental than that, in the application of the science, is the literacy of the climate system. And back to the basics about we're dealing with climate change, changes in the mean and variability. Those are new concepts to a lot of folks in public health. I can't tell you how many senior HHS people I have been on conversations with that have said, climate change, we just need better weather response plans. What more could you want? And I'm dumbfounded that, no, this means fundamental change in just about everything. And people don't really appreciate that. Once that hurdle is overcome, then we get much more robust engagement across the health department. So if our climate group doesn't have that expertise, they often go out and get it. go to the biometrics group or go to the surveillance group, but they've got to sell themselves all over again. So the hurdle always is this climate literacy, getting people to appreciate the magnitude or what really this problem is. I don't think we do a good job of communicating that.
Well, thank you, but I think the three presentations this morning with their use of GIS really helps visualize the output of statistical methods to locational analyses, and that's very useful.
Oh, you bet.
Thank you.
Hi, Jerry Poggi again, SOEH. Great talk. I'd like to bring it to a different context, though. I love your idea about 18 departments at local levels are now working aggressively on this. I wear a different hat, Vice Chair of the Human Services Council for Fairfax, Virginia. 1.1 million people. It's got a great health department, but it's also a department that occupies a role in the state that just refused to pursue Medicare expansion. That rebounds to the local health department in terms of taking over care. We have a governor who just balanced a budget by reducing funding that will mean no localities getting additional help from Richmond. Our current county budget is going through an internal planning process of a 3% cut in the budget for the coming year. So how do we work collaboratively with perhaps more advanced models that could fit a 1.1 million county at a time when we don't have resources to build new capacity, build new awareness? It seems like the barriers are enormous, and some of us are thinking by the end of tomorrow we may have the head of the Senate Environment Public Works Committee be led by a person who considers climate change to be a hoax. So we have big problems to grapple with locally in building the awareness and the capacity. If we can't do it from the federal level, if we can't get resources federally, we can't get resources statewide, we have to start working locally on how do we garner an understanding and appreciation across the publics to do local support for systems that maybe other cities, states, localities are doing, but ours isn't yet.
I concur. Yeah, we had a 4% cut, so I feel your pain. But it's a challenge. I think what people are doing is being creative, and they're taking small amounts of money and leveraging it from other sources. Other than that,
We welcome all of those tricks and strategies.
Hi, Ann Gramsci, EPA, and I would just like to, we appreciate that it's a difficult environment for all of us, but for me, this just strikes me as this is all just part of good planning. And so perhaps it's not something to be considered separately like an or, but maybe an and. I just wanted to make a comment. You made a mention in your BRACE framework about assessing vulnerabilities, and then you listed off socioeconomic kind of characteristics of individuals that make them more vulnerable. I hope you're also including, like community assets, like infrastructure, and availability or the extent to which they are fully maxed out on their electricity resources, water resources, and so on and so forth, that the vulnerability also includes more than just the individuals.
oh yeah, I was sorry for leaving that out, but we have the vulnerabilities are assessed by attributes of population or individuals and place. And we put out a guidance document in the summer as part of the President's Climate Action Plan on assessing vulnerabilities, a guidebook to assess vulnerabilities to climate change, the GIS approach. And it actually offers a multiple different approaches, because if you look out on the literature, there's a lot of really fine work on this, and everybody uses slightly different approaches, combined indices, the Susan Cutter approach, or et cetera. And we provide a kind of a menu of options. So in our guidance, we say, yes, of course, attributes of place, urban heat island, neighborhood characteristics, coastal floodplain, what John's working on with hospital infrastructure and access and to that is important as well.
So can I ask a follow-up? Is there any attempt to do this kind of nationwide? If you have some kind of framing that we could do a nationwide assessment of vulnerability to identify hotspots, for example, where you might be particularly vulnerable?
Well,
relative
that's not our
vulnerability.
ambition. Our ambition is to start at the state level and work down to the local level. So the state start that we fund and they do it statewide. Our next iteration, we want them to then push it down to the county, the census block group, or even smaller if possible layer to get much more contextualized data rather than spatial coverage. It has been done nationwide in a number of cases for different hazards. What's her name? Colleen Reed did it for heat. I think that you worked with her on that. It was your work.
Sorry, Ann, would you mind?
Sorry. Yeah, but you get the sense. It's really. One of the things is that if you had kind of benchmarking, that you could start to identify particular states or particular counties across the country that would be relatively more at risk. And you're right, Colleen's work is really important in that way because you can really zero in on places
Right.
which are vulnerable, but also have a lot of climate change. And so you can start to look for those quote-unquote hotspots. And it would be nice to see that framework extended beyond heat mortality, which is what we tend to focus in on. And I think that there may be sufficient knowledge of some of the modeling that's going on, as well as, for example, some work at DOE looking at infrastructure and so on and so forth, that it may be a time when we can kind of do that might yield some really interesting insights and also help us with targeting resources.
Yeah, or at least sharing them, yeah.
Hi, Peter Berry from Health Canada. Just working with public health officials and seeing the types of adaptation going on, and the importance of that adaptation, perceptions and stuff. I'm just wondering, with the U.S. assessment, are you looking at trying to model or further understand some of the adaptation components? Because we're finding that's a big challenge actually moving forward in terms of vulnerability analysis.
Okay, maybe I need you to clarify that. In the assessment is, the interim special assessment report is not going to do that. So that our work at CDC is not some model adaptations, but to identify which ones are actionable. There's a whole suite of options. Some of them are feasible from a political and a financial perspective, others more so than some. We're trying to identify how those work within a particular context and push those out.
Yeah, I guess in terms of projecting future health impacts and giving consideration to the effects of future adaptation on those health impacts, it's kind of trying to give some consideration to that in a fairly rigorous fashion. That's always been a big challenge for us.
Yeah, putting adaptation into any of these models is tough.
Yeah.
And how do you do that? That's been a big challenge of we're going to model this, but then you got to put adaptation in there. I don't know, Chris has done some work on it. I don't know. Maybe we'll hear about that later.
Just with specific reference to the U.S. GCRP climate and health assessment that we're doing, our emphasis has really been, at this point, trying to get the risk side right and focusing in on the hazard and risk modeling and assessment, recognizing that an accurate future estimative burden of disease really does require scenario planning of what the future is going to look like. And there's an infrastructure piece of that, there's a health behaviors piece of that, and there's a very important health adaptation piece of that. All of that has to be integrated for a valuable future projection of a burden of disease. But this assessment is not there yet. But one of the reasons we're doing the workshop today is to talk about this kind of thing. Thank you. So we've had a wonderful start to the workshop. We're going to take a break now. When we come back, we've talked about a lot of different kinds of health impacts. We're going to dive a little bit deeper into specific examples of modeling approaches to specific kinds of health outcomes and see where the state of the art is. So come back in about 10 to 12 minutes. Okay, thank you.